My name's Dr. Lucy McKay. I'm the CEO of a charity called Medics for Rare Disease, and I'm really grateful to be here today. I looked back, I think Sonia first contacted us in 2022, did a podcast with a colleague of ours, Melissa, and you've also been part of the Student Voice Prize, which is an initiative that we run with Beacon that is an essay competition for students, undergraduate and master's students in the health sciences about rare disease, wanting to hear from the voices, not only of people who are impacted, but how those students who take part, their reflections as well. And so it's been a long time coming that we've met, and I'm grateful to be here. And this is also a really important topic so words that matter, preparing professionals for conversations in rare disease. Words that matter. Disease isn't a great word, is it? And unfortunately, it's one the charity is currently stuck with because of how, the true span of rareness is also infections, it's also not conditions, they're not all genetic. And globally, worldwide, we are trying to work towards using the term rare disease to encompass a large group of people, 6% at least of the population. My hope is that one day we won't even have to talk about rare disease because we won't have to fight in the way we do currently. And so that's just my first caveat if I'm going to talk about words that matter. The main thing is our target audience is usually healthcare professionals, and we have to talk in their language as well. So I'm Dr. Lucy McKay, CEO of Medics for Rare Disease. Let's see if this works. Ooh, there we go. Come on. So our vision is equitable healthcare for everyone. And the brackets there is really regardless of the prevalence of the condition you are living with. And our mission is to shape a medical profession that can provide people living with rare conditions a timely diagnosis and excellent care. So that doesn't mean, in terms of timely, not the fastest necessarily, but timely means an appropriate time, supported, delivered well. And excellent care, you'll notice we haven't immediately jumped to treatment. We're talking about the whole of the care that people receive. We do this through 3 pillars of work, starting with advocacy, then training and network. We advocate for a single discipline approach to rare because there are approximately 6,800 different conditions, diseases, infections that sit under this bracket within Orphanet, the list of rare conditions and rare diseases. So it's impossible to teach about all of those different conditions. And really, that is how medicine is still done. Even though we have had a major push towards patient-centered care, I think we can all assume it's better than the patient-centeredness is better than maybe 50 years ago, but it isn't truly patient-centered. There is still a sense of your patient comes in, what is most likely to be affecting them? And this really is not a useful sort of mechanism for identifying and understanding people who then have rare conditions that you haven't been taught about. It requires you to have some idea before you even start looking into something. With over 6,800 conditions, that's just not going to be possible, so we need a different approach. So that's what we advocate for. We do that in policy, so government, we do it globally, we do it within the NHS, we do it to GP practices, everyone who will listen to us. And after people have got this concept of 6% of the population or 1 in 17 people in their lifetime in the UK, we then ask them to take some training because awareness by itself is not good enough. I'm sure, especially today, can think of a lot of things we're aware about and we're not doing anything to help. And it's really hard. But in the people we're talking to, which is medical professionals. So we focus on the medical profession, but do talk to other healthcare professions. And, this all works in one big healthcare system, which is all part of one society, which is all part of one globe. It all contributes. We are actually talking to people where it is their duty to provide excellent care. They are paid to do it. It's their job to do it, regardless of the prevalence of the condition. So therefore, awareness isn't going to cut it alone. They need to have training. So we do this through a model called Rare Disease 101. We like to say we teach about over 6,000 rare diseases without teaching about a single one. And we provide this online and in person, etc. Then we've also created a network of people who, once they've done all this, they're fully converted, they join our network so that they too can go on to provide advocacy, provide training, and so on and so forth, until we've engulfed the whole world and realize that every person, no matter who they are, no matter how long they live, are valuable, and we need to help them to live their lives well and in a way that respects all of their human rights. So one of the ways that we fund the charity is through sponsorship. So thank you to our 25 partners, but we work independently from them, and none of this content has been edited by them. So education around rare disease and sensitive communication in rare disease is limited. So I became a doctor. I did genetics at university, and then I became a doctor. We were founded by medical students who then became doctors as we grew up. And we currently have a doctor on our trustee board. We've got 3 no longer practicing doctors on our staff out of 5, which goes to show what it's like to work in the NHS right now. And also then we have a big ambassador network of lots of different healthcare professionals, some who also have rare conditions or are impacted by them. And so we can tell you this. Often there's like, show me the evidence. And it's like, well, the evidence is in what people and families experience, but also everyone who's going through medical education at the moment will attune to this. So they are chronically overlooked in training, but not only that, when rare does come up, it tends to be in a way that can be a novelty, so, there's this fascinating condition. And also we can play a bit of bingo here. If anyone has weird and wonderful on their piece of paper, you can have a tick. So weird and wonderful, that's what rare gets called as, but that's othering. People are not weird and wonderful. It is not weird and wonderful to live with a rare condition. Or as a way to teach science. So metabolic conditions are often taught about, a few of them, because they relate to a specific part of a metabolic cycle. But when they're in those lectures, they're not being taught about the impact on the patient, the family, the coordinated care that is needed, the recent research that has provided hope. And if you don't diagnose them, they won't get it. They're in a science lesson at that moment. Or to teach about a genetic type of pathway, so an inheritance. But not all rare conditions have a genetic origin, and not all rare conditions that have a genetic origin are inherited. And then when people talk about that, they get sort of pigeonholed. So Fragile X is a fairly well-known rare condition. It occurs in women, it occurs in female people, and it also occurs in male people. But I'll tell you that all of the multiple choice questions through medical school will talk about a boy who's got behavioural difficulties and other things. And Fragile X actually have to go out and say, girls get this too. Because when it's been pigeonholed like that, and that's the only time you'll hear about it, unfortunately, that's what happens. But this leaves healthcare professionals unprepared and not confident when they are then actually having to work with families and individuals who they are not prepared to look after. They've been told their whole lives, it's weird and wonderful, you'll never see it, it's so rare, whatever. And then suddenly the reality is in front of them. Imagine thinking of delivering a cancer diagnosis or even talking about cancer without the communication skills that goes with that kind of thing. And yet every day, people and families are receiving very difficult diagnoses and poorly coordinated care that we do really well in another area of medicine. So the good news is communication skills can be learned. That goes beyond the classic. There's no doctors here, but that must be difficult for you. We can even move beyond that. If that's our first step in, we can move beyond. They can be learned. They're often tools that healthcare professionals already know. They're often tools that healthcare professionals already use all the time. And they have experience in this. But if nobody has ever told them about this area of rare disease, and then now they're faced with things that they also haven't been told about or taught enough about, short lives, baby loss, child loss, sometimes these very well-known skills go out the window because they are scared. And when you're scared, you turn off this part of your brain, the really useful frontal cortex with all the thinking, and you turn on this part of your brain, that sort of primitive brain, and you start panicking. And when people panic, they say things they wouldn't otherwise. And I truly believe that this is where we are. This is where we are in all these conversations. And I truly believe that, if everyone went back to their doctor or their healthcare professional in 10 years' time and said, you said this to me, I don't think they'd remember it because they were in a state of panic and they said the wrong thing. So how do we do that? Well, we do it all the time. We teach people to see someone lying on the ground and potentially save their life through CPR. If I see someone lying on the ground, the first thing I do is go check them, ABC, is it okay? Can you hear me? Can you hear me? So if you're not having a panic response at that, we can sort out having a panic response at someone having a rare, a genetic or a difficult diagnosis, as long as those people are well trained. So we just need to apply it to the rare disease scenario, is my personal opinion anyway. So that's the good news. This communication skills can be learned and this can be moved on. So, and we know that dialogue with healthcare professionals shapes experiences. We know that what is said at certain moments in people's lives stay with them forever. And that's why I said at the beginning, words can harm and words can heal. And there are certain moments in someone's journey with a rare condition or a genetic condition that will stay with them for the rest of their life. And we want to make sure that those people are in the hands of people who can heal, not harm. Imagine getting someone who has been shown to not be that competent with a scalpel to start opening someone up on an operating table, because that's what it is, it's scars. And I think the real thing about rare disease is there's often no treatments for conditions. They can be very complex. They can cause really difficult symptoms. These are just the hard things about it. There are joys, there are opportunities like anything in life. But that means often the only tools we have in rare disease, or the biggest, is communication. And so if we are using a knife, not some kind of lovely Manuka honey balm, then that person gets 1,000 cuts over and over again. So why should we bother? Hopefully I don't need to teach this audience why we should bother to think about these communication skills. But we know about the lasting impact. We also know that dissatisfaction with clinical care is usually due to communication, not purely down to the clinical occurrences. It's usually down to communication, or a big part of the reason that someone has complained or someone is raising a problem is because of the communication piece. And psychologically safe communication can permanently change someone's outlook in terms of their clinical care. So when someone is delivered difficult news, if that is done in a psychologically safe, supported way, it can change and improve how that individual relates to their condition or their child's condition, how they feel about their future, how they trust and interact with the healthcare system for the rest of their lives, how their families trust and interact with the healthcare system for the rest of their lives, and the interpersonal relationship between that healthcare professional and that patient. And we know that because in rare disease, we have people who are attached, really emotionally attached to their clinician because they know they've got a good one, or because they know this person is there for them. They're worried about they won't leave. They won't leave the area. They won't move abroad. They worry about that person retiring. They're almost weighing up their boyfriend versus their loved one versus their consultant, because they become attached because they know they're safe in that person's hands. They trust them. That doesn't mean that person has gone in and saved their life, but very, very unlikely in a rare scenario. But they've given them something that they know that many people in rare don't have. And we would like that to not be such a unusual occurrence that people feel they're lucky that they have it. Really trust and knowing that when you go into a healthcare professional situation or a situation in healthcare, trusting that the person, has a good idea of what's going on with you, how best to look after you, and how best to support you, and to do that in a non-judgmental and equitable way. That really should be the least we give people. So communication really does impact health outcomes. So never underestimate the power of your words. They will often stay with patients' families for years after you have forgotten them. Early conversations in particular aren't forgotten. This is a quote that the diagnosis seemed to make it okay for a senior doctor to talk about her dysmorphic features. That's another bingo for me, dysmorphic features in the wrong hands as a word. Even 8.5 years on, I'm still hurt by his blunt appraisal. So when we're thinking about delivering when I was taught it was called delivering bad news or breaking bad news. We got some nods. Delivering difficult news. And when we were taught it was always about someone had to be dying. It was often in an end of life situation you talked about it, or a cancer diagnosis. I certainly was never taught how to deliver this when we're talking about young people. So here's some ideas on how to deliver difficult news well. So a couple of studies have explored the experiences of parents and caregivers of children who have serious or life-limiting conditions. And these show that the challenges when it comes to having these conversations. So timing, delivering a diagnosis at an inappropriate moment, such as over the phone, without preparation, or in a busy setting. And that was also, it was a common reason for people to be dissatisfied. And it also included delays, meaning that parents found out critical information too late to be able to make decisions. So, they're technically being told things technically in time, but really not with enough time to weigh this up. Anyone who has been pregnant and giving birth or experienced pregnancy and birth ever, I'm not just going to say in the UK, but that can be frequently an issue, that you are on a time limit, and when you have the information might not be the best time to get it. So not being involved or not seeing parents, patients, carers as partners or equals. So parents and caregivers describe feeling like passive recipients of information rather than active participants in that conversation. and not being asked for input or offered choices. And really that can diminish the way that people feel about those choices, about what's being said. It's being done to them instead of being met by that healthcare professional. And remembering really that healthcare professionals aren't there to tell anyone what to do. We are there to advise on what options are, discuss them, what can be done. So conversations happening without warning. And this became a really big problem during COVID. So I recently, one of my family friends received a diagnosis. She had gone to an appointment with a consultant, prepared with her family and her husband. But then when she went to get the news, it was a phone call. And so she thought, well, it's just a phone call. So that means it probably, they said, oh, we're going to test for this really rare thing. It won't be that. We're just ruling it out. We're just ruling it out. And so she received a phone call and said, oh, are you okay to take, we've got your results. Are you okay to receive them? And she's thinking, well, surely it's not going to be the really, really impactful, rare, genetic, inherited, autosomal dominant condition, because who would deliver that over the phone? And it was. She was the first of 8 in her family to receive that diagnosis. She received it on her own over the phone. So receiving that without warning, on your own, no support, no context, that moment will shape her relationship with her condition from then on. So, not being followed up. So parents and caregivers often reported that after receiving a diagnosis, there was no clear plan or offer of follow-up, or sort of too much information was given too soon, because we work in a system where there is no opportunity for follow-up. So we've got to be fair to the people who work in our healthcare system. They might really want to follow you up soon, but if that isn't possible, what do you do? Do you give people very little information, or do you give them all the information you have? But as much as we acknowledge that difficulty, there are ways to get around this. And we do still have community services. We do still have phones. And the thing about rare conditions is they are still rare. So they might be collectively common, but they are still rare. So if there's one person that you're going to pick up the phone to check on the next day, we would advise it would be the person you've just delivered a very, very difficult diagnosis for. Think about it in terms of cancer, a cancer diagnosis. You are unlikely to receive a common cancer diagnosis without some form of clinical nurse specialist there or on call. You will receive follow-up afterwards for that, not necessarily by the diagnosing doctor. And while that system might not automatically be in place in rare, it doesn't mean we shouldn't be trying to do it wherever we can, if possible. So avoid acknowledging uncertainty. So this might sound like a suggestion. The idea is these are the difficulties that people can complain about. When healthcare professionals don't acknowledge uncertainty or lack of information, it doesn't help families and individuals. No healthcare professional can be an expert in every rare condition. However, they can adequately prepare for consultations and acknowledge where the unknowns remain, where the uncertainties remain. Also, they can say, I don't know about this yet, but we can go together. We can go find out things. I know some places where I can find out more information about rare conditions, and I will do that for you. What kind of information would you like? So a lack of openness about uncertainties can be perceived as avoidance, or that, the potential is worse. I think most people, when called into difficult conversations, are thinking the worst, and they're going to go the absolute worst and beyond. Google will certainly take you to the absolute worst and beyond. So if the healthcare professional doesn't put a limit on that, doesn't ring fence, yes, this is difficult. No one is saying this isn't difficult, But there is a limit to that, and we don't know what that is yet. So let's make sure we get all of our information. Then we have families and individuals going off on their own, and that's certainly not good for them or their mental health. Then use of jargon. So, I've missed one. Involving too many or unfamiliar professionals. So this is in terms of when delivering that difficult news. So parents and caregivers reporting feelings of being overwhelmed or uncomfortable. They're getting a difficult diagnosis, but they're surrounded by people they don't know, or there's lots of people there. Again, that might be because this, unlike other areas of medicine, where this is quite a well-known track, you're going to give this diagnosis, take my bleep, take my phone, don't tell anyone to contact me, everyone, I'm in this room, don't come into this room, it's taken, is what you do. In this area of medicine, people might not have made all of those calculations beforehand, as is sort of normal. I used to work on a stroke ward. I also worked on palliative care. You sort of know immediately when you're going down that track. In this case, you might not realize, and it's too late. And you have a medical student in the room, and you've only got a few minutes and all of these things, which is why it's critical that we do this training so that people might not see the exact diagnosis and understand if it's a rare condition, there might be these conversations coming up. And then use of jargon. So the technical or medical language often confuses parents and caregivers. It can be insensitive, and it could be challenging, and it might be especially pitched wrong. We have words in medicine that can be used in medicine, but should not be used to the people who are impacted. So it's like they're tools. They're tools. For me saying, if I'm a clinical geneticist and I'm talking to a clinical geneticist and I use the term dysmorphia, then maybe that's okay, because we know what each other are talking about. Someone else using that term who isn't as well trained, doesn't know how to use it, has potentially made presumptions that are very weighty, could cause real harm, especially if they use it to parents, patients, etc. So jargon can be difficult for all the reasons we know, you don't understand, etc. But also in rare disease, it can be the barrier the clinician puts up between them and their them and the person they're talking to, because the clinician is scared because they don't know, because it's a rare disease. There's not loads of information about it. So they've looked up what they can. And so therefore, they haven't got loads to give. So they're going to just give this stuff. It kind of reminds me of, when someone is starting out as a doctor versus many years on. At the beginning, it's like, well, I palpated their abdomen and I felt a 4x4 mass in the da-da-da-da. And then, later on, it's like, oh, their tummy felt hard here. They've got confidence, so they don't need to show their knowledge and ability through fancy words. And I feel sometimes that fancy words are used as a barrier because they're scared of stepping into the unfamiliar. So I think we've sort of covered the whole point about words having power, but it's not just when and where and whom has these conversations, the actual words which we have said today. So some of the ones I would really like to throw in room 101, never to be seen again, are failure to thrive. That was my daughter. Incompatible with life. The poor use of dysmorphia. The things like, oh, it's rare. What do you expect? Or, one of the things that people would say to me is they'd say, how many siblings do you have? I would mention as a child that I had a brother, but he died. The absolute fear that would bring into adults. And then I go, to help them out of the fear, as a child, I'm going, it's okay, he had a rare genetic condition. Because it would bring them out. They think, oh, that's okay then. I can go on with my life now, knowing that that is not relevant to me. I've done half an hour, so I will just move on to, here are some suggestions. And there are a few guides like this, and I would love to keep continuing. This guide comes from, I believe, from Genomics England. I would love to continue this. I think this could be a piece of art if we really all got together. I think hopefully people have heard about microaggressions, which has become a more familiar term because of anti-racism teaching. So the idea of these small but repetitive and concurrent and constant little phrases or words related to someone's race or their looks, adding up and adding up and adding up towards that person feeling devalued or having mental health problems because they are being seen as other, even if the people who are giving those words do not think that they are being racist or treating them as other. They are, and how it adds up. I feel the same in the genetic community. Our 5 tips. So, collaboration, remembering that caregivers, parents, partners are equal partners in the consultation. Ask them for what information they want, invite their experiences and perspectives, and allow time for questions. We talk about involve, believe, no, hang on, sorry. Listen, involve, believe. No, start again. I'm going to get it the right way around. Listen, believe, involve. Believe is the big one there, I think, because I think it's a lack of truly believing what people are going through that leads people out in the cold. Information, make sure you prepare well. You don't need to be an expert, but use those communication skills and find out from the people that you're talking to, what level of information do they need. If you haven't given enough, reconvene, come back. This isn't a one-shot thing. People with long-term conditions, their long-term conditions, you will see them again. Provide written information, provide advice about support groups like Soft UK and many others. Compassion. Remember to consider your choice of vocabulary, those words when discussing rare and genetic conditions. Allow time and space for people to process their emotions. Difficult news can cause difficult emotions. That's normal, and allow that time. And give subsequent follow-up. And then hope, as well as acknowledging the difficulties, the hardship, the pain, the loss, the sorrow, bringing hope to your consultation. And that's something that people really talk about in this area. Healthcare professionals really worry about giving too much hope. And we tell them, really don't, because the feedback from the communities we talk to is you leave them devoid of any hope. And I think that this is a reason we love working with Soft UK, because of people being told one statement, your baby will live for X long, or they will not thrive outside the womb, or they will not live outside the womb. Not only is that completely devoid of hope, it suggests you know everything about every baby, even before they're born, but also say that child does go to live for 10 days, 10 weeks, 10 years, you have left that family completely without the chance to prepare. So better to say you're not sure, I think. And then the last slide is patient advocacy groups, patient advocacy groups, patient advocacy groups. I was brought up on a patient advocacy group. When everything else disappeared during COVID, who was doing the work? It was the patient advocacy groups. 30 years ago, when rare disease was less in the news or in policy, who was there starting all this? It was patient advocacy groups, and they will be there in the future. So if you can do one thing for your patient who has a rare long-term or genetic condition, it is make sure that you have gone to a patient advocacy group, because not everyone is able to use the computers as well as you are. Not everyone is, it might have that, it's brave. It's brave to reach out. And if you can do it for them, you don't need to give any information, we don't need to worry about confidentiality, then it means you will have shown them you're willing to actually do something for them. And that will also mean a lot. So summary, early conversations that we have with families have a lasting impact. Make sure that that impact is a positive one so that you can continue a good relationship with them that will provide them with the best health outcomes available to them. That your wording matters, and remembering those really important moments, pre-diagnosis, at the actual diagnosis, post-diagnosis. Timing, collaboration, information, compassion, and hope, and those tips that I just went through. Write them down and take them with you until you no longer have to read about them anymore. So thank you very much. We're Medics for Rare Disease. I'd like to thank my colleague, Dr. Helen McGuinness, who provides these slides and all the things that help me be able to present to you. We have a podcast, and I can share it, which is, Sonia was on the podcast, but I really hope that you'll come back. And we've also got Rare Disease 101 training on Learn.